Hi, my name's Nicole Rasmussen and I'm the Director of Patient Safety and Improvement at Alfred Health. Over the next little while, I'm going to take you on the hitchhiker's guide through the galaxy of clinical variation and also a practical approach to the identification and management of unwarranted variation. Before we begin, I would like to acknowledge the Boonwurrung clan of the Kulin Nation, who are the custodians of the land and waters on which I stand, and pay my respects to the elders past, present and emerging. In terms of where I'm coming to you today is from the Mossroom, which is the recently opened Innovation and Education Hub at the Alfred. So behind me you'll see a solid wall of green, and believe it or not, that's actually live moss, and this surrounds all of the walls of this room. The intention of this room is to promote thinking and conversations that are energised, expansive and elevated, and I thought that's quite fitting given the conversation that we're hopefully in the presentation that we're covering today. A little bit about Alfred Health. So we are a quaternary health service located in the inner Bayside suburbs of Melbourne, metropolitan Melbourne. We provide acute, subacute, community and specialist outpatient services, as well as I think a total of 17 statewide services, so essentially caring for all of Victorians. What this means is that at any one time we've got over 50% of our patients that are with us actually reside outside our immediate catchment area. We're a major provider of trauma service, and we have a sizable ICU of 44 beds that split over two levels, creating a surgical and a medical ICU service. So essentially we care for some of the most complex and sickest patients within our state. And that context is particularly important as I'll step through one of the examples of clinical variation analysis and improvement that we've undertaken at Alfred Health. So why are we focused on clinical variation? Variation in practice in and of itself isn't bad as such when it's aligned with or in accordance with a patient's clinical care needs or in accordance with a patient's preferences and healthcare choices. Variation that isn't aligned with these factors can lead to suboptimal patient outcomes, patient harm, and ineffective use of clinical resources, either through over-servicing or, importantly, under-servicing, where patients don't receive or have access to the care that would make a big difference to their quality of life. It's difficult, I think, in healthcare. We have finite resources, multiple priorities, competing priorities, and loads of data. So it's really difficult to identify where or how to begin. And this is where the user guide to review of clinical variation is important. It outlines some key priorities, key criteria that health services can use to inform their priority areas. I've listed just a few here that are most relevant to Alfred Health and that we routinely use to inform our identification of areas for priority focus and analysis. So the next step is identifying how to assess clinical variation. And the first part to this is actually looking to the data that's available. And in my mind, this forms into two broad categories. One is around a top-down approach, and the other is bottom-up, which I'll come to on the next slide. The top-down approach consists of benchmarked external data. Some examples are listed there, but I'll pay particular attention to clinical quality registries, as this has been an area of focus for us at Alfred Health over the last 3 to 4 years. The clinical quality registries are an important data set that provide oversight to the appropriateness and effectiveness of care delivery within a very specific domain. They provide opportunity for comparison against performance against our peers, and also provides an opportunity to identify outliers where they occur. Alfred Health participates in over 70 clinical registries, and 25 of these consist of benchmarkable data, and they've become a critical data set that we routinely review and use to inform our opportunities for improvement. Interesting, the clinical quality registries also align, some of them align to the clinical care standards. So it allows for a streamlined approach to the evaluation of the performance against those clinical care standards. So they're a critical information source for us around appropriateness, effectiveness of care. The other data set is bottom-up, or what I consider internally derived. So it's information and performance data around our quality and safety delivery often at a patient level or unit level. It's learnings from serious adverse event reviews. It's the learnings or referrals that come from mortality and morbidity review meetings, and also, of course, the comparison of performance either across units, quality and safety across units within the health service, or aligned with those external KPIs and benchmark targets. So once you understand the data set that's available, you identify which data sets are appropriate for comparison in line with the priority area that's in focus. The next step is to undertake analysis. And the purpose of undertaking analysis is to identify where there is clinical variation, but importantly, understand where that variation is unwarranted and identification of opportunities for improvement. It's at this point that the data in and of itself will not provide the answer. It's important to engage the clinical workforce and the expertise that's within the health service to help understand and accurately triangulate the data to form a picture around patient care and outcomes. Importantly, engagement of clinicians and the custodians of the data is important. We found that particularly the case with the clinical quality registries, because it's understanding the data definitions that sit behind that, the risk adjustment, if there is any, and so on. Equally important is to consider the interdisciplinary team beyond what we traditionally consider to be medical, nursing, allied health and pharmacy, for example, but drawing on expertise within the organisation that provides a more holistic lens of the data that's available for the analysis. So that's where calling on the health information managers because of their coding expertise, and also the health informaticians that are within our performance units. Using the triangulation and the deep dive into the data, combined with the important conversations and analysis from clinicians on how they're delivering care, goes a long way in identifying what are the contributing factors to variance in clinical practice, and what are those contributing factors that can be improved to help minimise unwarranted variation. Documentation, audits, observational practices, all of the observation of practice are all important data sources or information sources to help create that picture of where we need to improve. This slide is information dense, but I really just wanted to illustrate the coming together and the interdisciplinary analysis occurs in lots of different ways. We've got risk-based committees, so where there are identification of clinical risks, they are aligned to those established committees and they have the clinical leadership around the table to inform where we need to improve. We have an evidence-based review committee, and the committee is probably not quite the accurate term. It's probably more of a council in that it's not decision-making, but it provides the organisation with recommendations based on the evaluation of best practice and ensuring that practice is consistent and cost-effective. It's really underpinning those appropriateness effective domains of quality that committee oversees. The other element is around topic-specific working groups or task forces, and these arise in response to emerging risks or in response to the coming together of people that are enthusiastic, curious and have energy about understanding the appropriateness of the effectiveness of the care that's delivered within their domain. So here I've given the example of our hospital-acquired complication working group. Others, for example, in more recent times, there was the sternal wound infection task force. So again, bringing senior clinicians together with the right people around the table to be able to accurately understand the clinical workflows that are leading to the patient outcomes and identifying opportunities for improvement. I'll step through an example at Alfred Health. This is an actual, whilst it says case study, it's actually an example of where we've identified clinical variation and suboptimal patient outcomes, and where we've had a targeted intervention approach to improve patient care in this space. It relates specifically to hospital-acquired anticoagulant-related complications. In terms of this particular issue in patient care, we knew that we had a problem through our serious adverse event process. And we knew that we had patient mortality where suboptimal anticoagulation therapy had been considered a potential contributing factor to the patient's outcome. It's been identified as a risk on the high risk register, And in review of patient-level data as part of the routine audit against best practice guidelines, it also identified challenges, and in conversations with clinicians, identified the challenges that they were experiencing on a day-to-day basis caring for our complex patient cohort. There's often conflicting indications for prophylaxis management, managing that delicate balance between the risk of bleeding versus the risk of developing an inpatient PE or DVT. It also was flagged, we've also been flagged as an outlier in the Health Roundtable data around the hospital-acquired complication, VTE, hospital-acquired VTE. So all of these came together and formed a picture that we had an issue and we needed to have some targeted intervention to understand what the issues were and then address them systematically. So what did we find as part of that analysis? Convened the interdisciplinary group. It revealed lots of useful insights that helped then inform the improvements. Completion of risk assessments on admission wasn't as consistent as the evidence would advise that it should be. Talking with clinicians, it highlighted the challenges that they faced in terms of the complex patient cohort, particularly the surgical patients, and trauma being a significant proportion of those. Documentation of mechanical prophylaxis. So as part of the medical record review, identifying patients that clinically would have been appropriate for mechanical prophylaxis, yet there was no evidence of the consideration for that as an intervention. And then the fourth point, which was perhaps the most interesting, and also it's an important learning, was that there are some cases where patients, despite our best efforts, they developed an unavoidable DVT or PE. And this was due to, again, the complex nature of our patient cohort and the unmodifiable patient factors that contributed to that patient risk profile. But altogether, it provided a roadmap, really, of where we needed to improve, implement strategies to support clinicians, and they're listed here. As you can see, it's a comprehensive program and it's been underway for quite some time now. As a result of the reviews, a dedicated VTE specialist pharmacist role was established. They carry a pager, the numbers on it spell out clot, and they're a fantastic resource that's at the elbow, at the end of the phone, for clinicians to be able to obtain advice when they're navigating those high-risk patient groups, and the surgical group, as I said, in particular. The governance has been established. There's a well-established anticoagulation stewardship committee. It's modelled on the antimicrobial stewardship approach. And again, senior clinicians around the table have very clear remit in the oversight of the safety and quality of care delivery within this particular domain. We had opportunities with the implementation of the electronic medical record, which was rolled out a couple of years ago. As part of that design and implementation, there was the opportunity to build in evidence-based practice and guidelines that to support clinicians at the time in terms of clinical care delivery. This occurs in the form of risk alerts. So there are alerts that trigger and prompt clinicians to complete VTE risk assessment, and also to then guide them in appropriate care management. And then lastly, there's been intensive effort working with the clinical units, targeting those high-risk patient groups and tailoring the evidence-based practice guidelines to better meet their unique care needs. So has it made a difference? And the answer is yes. So you can see over the last 4 odd years, we've managed to achieve around about a 66% reduction in the rate of hospital-acquired PEs and DVTs. So it's fantastic. It's certainly, we're kicking goals. You can see from this slide that in terms of the risk profile of medical versus surgical patients, you can see that the surgical patients continue to be our high-risk group, but they also are heading in the right direction in terms of the occurrence of hospital-acquired PEs and DVTs. But the challenge is, do you think we're there? Have we solved it? Have we arrived at our destination? And the answer is no. It is absolutely a journey. We're continuing to do a deeper dive with our Health Roundtable data to better understand the contributing factors to our outlier status, with early indications with thinking that it's the trauma cohort that are contributing to that. It remains on our organisational risk register, and just recently we've identified a couple of key metrics to elevate it to the executive or organisational quality and safety performance report, so that it has that high level view and profile in terms of this being a particular risk for us. And then, of course, continuing to work with the high risk groups, for example, burns patients. We provide a statewide service for burns, and working with that particular group in, again, tailoring the evidence-based guidelines to better support those patients. So in summary, a systematic review of clinical variation is an iterative journey, and it needs to be underpinned by strong clinical engagement as well as data-led continuous improvement. Embedding and integrating the approach with the clinical governance framework of your given health service will provide a solid foundation for enduring oversight of the appropriateness and effectiveness of healthcare delivery and patient outcomes. Regardless of where you are on your journey, make sure that you stop, you pause to celebrate your wins and successes in improving patient care and sharing your learnings along the way. For Alfred Health, this takes the form of a Chair of a Board Award for Patient Safety and Quality Improvement. We've got a couple of examples of last year's winners there on the screen for you. It also takes the form of share and showcase events for our clinical programs, providing them opportunity again to identify where they've to share where they've identified opportunities for improvement in the clinical care delivery and the achievement of improvements in patient care experience and outcomes. For our clinical units, they provide an annual report presenting their quality and safety performance over the year and highlighting any key improvements that they've undertaken and outcomes that they have achieved in terms of progressing, improving patient care. The annual audits consist of, there is a requirement that it consists of benchmark data. So there certainly is the maturity in terms of that analysis of performance and the identification and proactive management of unwanted variation. This concludes my journey with you to the Hitchhiker's Guide of Clinical Variation, and I thank you for your time. I'll leave you with the wise, friendly words of Douglas Adams, and that is, don't panic. And I wish you all the very best on your own journey through the review of clinical variation and improving patient care and outcomes. Thank you.